Thanks, John. And indeed, thank you to the organisers for the invitation to speak. I actually chaired the Young OR, as it was called then, conference in 2005 at Bath, so it's special to be back and give a plenary talk 14 years later. So OR saves lives. Well, we know that operating rooms saves lives, but I want to tell you about how operational research can also save lives. So there's a much younger looking Harper. 1996, Britpop, Oasis, Blur. England hosted the Euro Championships in football. Sudden Gareth Southgate missed a penalty in the semi-final. And I found myself in the summer of 1996 in Mumbai. That's the gateway to India. I was an MSc student at Southampton University, and I was lucky enough to spend 3 months in India working on modelling HIV and AIDS outbreak there. And that was really my first kind of taste into how modelling OR could be useful in healthcare. I then worked for a couple of years before going back into academia and a PhD student at Southampton and stayed on for some crazy reason. Gave up a good salary at Capgemini. Anyway, that's in the past. I want to tell you a bit about the research of the group at Cardiff. I've been at Cardiff now for 10 years. Actually, soon after I joined Cardiff University, took up the chair position. Actually, a lot of research in healthcare is born of personal experience. And we not long moved to South Wales. We live in Monmouthshire, about 40 miles from Cardiff. So it's quite a kind of semi-rural area. About 25 minutes on the dual carriageway down to Newport. So it's a little bit out in, it's nice countryside near, if you know that area, near Brecon Beacons and Wye Valley, etc. But we have 3 children, and my middle child, Ruth, she was about 2 at the time, and she had a convulsion one evening, and so she fitted and she went, she unconscious, and it was late at night, and of course as parents you're absolutely panicked and so on. So what you do, you grab the phone and dial 999, and what you expect is a kind of speedy response. So 45 minutes later, we're still waiting for an ambulance. Eventually an ambulance came. It actually was an English ambulance. It came from the Forest of Dean because there was no Welsh ambulances apparently available. And this happened also 2 or 3 weeks later. My wife was travelling along the Wye Valley in the country and looked in the rearview mirror, and again Ruth had was a convulsion again and fitted, unconscious, couldn't get a mobile signal, had to find a house that someone was in, phoned the ambulance. 15 minutes later an ambulance comes, another English ambulance, and so on. So my wife says, well, if you're any good at your job, you can try and help the Welsh Ambulance Service. You brought me to South Wales, so there was a challenge. So I contacted the R&D manager at the Welsh Ambulance Service. I did a little bit of research. It turns out that the Welsh Ambulance Service at that time was the worst performing ambulance service in the United Kingdom in terms of, as measured by the ability to meet the 8-minute response time target for the most severe category. It's only less than half of all calls were met in 8 minutes. So if you're having a stroke or heart attack, it didn't sound like good news. And then Monmouthshire was the worst area, the worst performing area in the whole of Wales, where we were living. So I guess it might have been the worst area in the whole of UK, if you want an ambulance. So after a lot of dialogue with our R&D manager saying, why would someone from maths and OR, what it is and what an OR is, why you want to help us? What mathematician going to help the ambulance service? So that kind of story led eventually to access to lots of data and to 2 PhD students, Leanne and Julie. So there's two PhDs worth of work with Welsh Ambulance Service. So I want to tell you a bit about this first before summarising some of the other impact. I'm going to pass through the story fairly quickly. There are a number of publications if you're interested, or you can contact me after about some of the work. But in summary, the work can be thought about as 3 areas: forecasting demand, then the response in terms of rostering and paramedics and so forth, and then location. So where do you locate ambulances on a network? So some really interesting kind of OR type problems in here, and we contributed to the literature in many ways and actually impactful research, which I'll come on to. So for example, demand, that's actually a time series of 999 calls across the whole of Wales over a 5-year period. Does anyone want to hazard a guess about what these extreme values are? So it's 4 to 5 years worth of data. It happens at the same time every year. When does the number of 999 calls go through the roof? Yeah, New Year's Eve, yes. So everyone likes to party hard on New Year's Eve, particularly in Cardiff. So these are extreme calls, events. There's no reason why these particular low events occur. We couldn't find any reason why there would be less 999 calls. It could be errors in the data, but there was no particular date or relevance or holidays, whatever. But generally, you can see that the time series shows an increase over years, about 3% per annum in terms of 999 call growth. But of course, inside that is it's a whole lot of patterns around day of the week of the year, etc. So again, I'm just simplifying this for the purposes of the presentation. But Julie actually spent a lot of time looking at forecasting 999 calls. Held back some data, and actually, we actually found, there's a paper on this in JAWS at the time. The true demand is the blue here, and you can see it's very day of the week dependent, and it's very seasonal, of course. As you get to December, one of the hardest months to forecast, you suddenly get the Christmas period, and you get the New Year's through the roof kind of idea. Now, some of the kind of more traditional forecasting methods pick up this kind of weekly variation, but don't respond very quickly to these sudden fluctuations, which are like in July for summer holidays also has an effect, Christmas time. But SSA, a singular spectral analysis, we found as quite a good technique, which was very responsive. And we were able to predict within about 2 or 3% error the number of 999 calls for the Welsh Ambulance Service, both regionally and across the whole country. So that was very useful because at the time they had very little capacity or intellect in terms of forecasting, apart from a 6-week rolling average was the best they could do. And we never set out to show that they weren't performing very well, but we set out to help them in terms of forecast better than they currently were. So with information about daily demand, and we could forecast like tomorrow's demand, a week out, even a few weeks out, that was helpful, as coupled also with time dependency during the day now. So again, this is kind of the pattern you get across many days of the year, where you get a dip in the number of 999 calls. This is now for a particular region, the southeast region. You see the drop down here, and then it steadily rises as people start to wake up in the daytime. Actually plateaus out largely in the daytime. And then it drops most evenings apart from Friday and Saturday nights when it starts to rise again. So again, we were able to do forecasting around the actual day by day, hour by hour trends. So what? So we can now do some smart forecasting of 999 calls into Wales. So of course, coupled with that information, we can start to think about how you respond to that. How do you put paramedics on in terms of different times of the day? How do you make sure you meet your time targets and so forth? So again, I'm condensing a lot of Julie's research into a slide. But what was nice about some of the mathematical work for this was that this actually is, if you think about it, is a time-dependent, highly time-dependent, priority queuing system. So why priority? Because actually, if you look at the categories of care for ambulances, they categorize them into things like A, B, and C type calls. So A is the most severe category, the 8-minute guideline for the most critical patients. There's category B and category C, which are deemed not as critical, but have a 15-minute or 21-minute target time as well. And the Welsh Government had a 65% target for all category A's within 8 minutes, for example, and there was also target times categories for B and C. So what's interesting about this is that you have a priority queue where the A's get to the front of the queue before the B's and C's. So from a queuing theory perspective, and what was nice for Julie's work, was we're able to do some time-dependent priority queuing systems. And these are notoriously difficult if you're working in the area of queuing theory. Steady state as usual, but time-dependent, but plus the priority, and that led to some new mathematics and some new queuing formulations. But what was nice about all of this with the time series, it was all embedded in a nice, easy-to-use Excel spreadsheet for the Welsh Ambulance Service. So they put the data in, fed it in automatically, historical data. It produced the forecast, the SSA forecast, it coupled with the queuing theory, and basically that allowed us to say things like this. So how would you need to roster your paramedics, your crews, to cover the demand to ensure the 65% target for Welsh Government? And you could play around with these in the Excel spreadsheet. And the shift patterns are defined along the bottom. Again, they can be changed. Now, what was staggering at the time with Welsh Ambulance Service is to find out that they have a roster for life policy. So all their paramedics work exactly the same every day of the week. And they know exactly when they're going to work this time next year. It's the same pattern. They don't flex their rosters. It's a bit like a supermarket having the same number of checkouts open every day of the year, which it clearly doesn't. So it's not responsive. So it's still an ongoing discussion, actually, with Welsh Ambulance Service, but they gradually move into more flexible workforce arrangements with the unions to actually cover the peak demands rather than having the same number of ambulances on at the same time every day of the week. Anyway, so the tool allows you to look at that. And some of Julie's work actually led to optimal allocations of shift patterns where you stagger the start times of paramedics. There are even cases, terrible stories, where all the paramedics started exactly at the same time of the shift. They took their break exactly at the same time, mid-morning, and someone phoned for 999, and there was no paramedic available to answer the call, and the person died. That happened. It's a true story. In South Wales, and that was in national news. But it just shows the inability, the inflexibility of the current rostering not to meet demand. So we did a lot of work, and we've been influencing Welsh Ambulance Service about their rosters. The other piece of work is about location. So Leanne's work now. So we have all this nice forecasting tools and so forth, but actually this is really interesting research as well, location theory. So kind of location allocation type models. Where do you locate your ambulances on a network enabled to try to minimize response times, for example, or maximize outcomes, which I'll come on to, which is really interesting. So this is a representation of South Wales. You actually live up here. You can see straight away, I'm right on the border. I'm about 2 miles from the English border, so I can always escape if I need to, back to England. So you can see straight away why it might be tricky for an ambulance up here, because actually the biggest city is Newport. It's a 22-mile dual carriageway ride. So the ambulances get sucked down into Newport, the big cities. So when you do need an ambulance call up here, they have to travel back up because they get pulled in different directions. The representation is meant to be that the blue dots represent major postcode sectors. The granularity of this type of modelling can be any granularity you like. So you can go for postcode sector, like CF24 for Cardiff or lower. But just for argument's sake, let's say the blue dots represent major towns or settlements across South Wales. It could be any map, any geography. The tool designed for flexibility. So this is where we know demand is coming in from these blue dots. And we also know when that demand is going to come in because we've done the forecasting work. So we actually know the time profile of demand. So we can predict there's going to be a 999 call, for example, here with some likelihood within the next hour or so at 9 o'clock on a Wednesday morning or whatever. The red dots represent ambulance stations, the current locations of where they have their fleet. And what's also interesting in this type of problem is that there's not just one vehicle type. So there's the standard ambulance that you see on the roads with the flashing lights. They don't go terribly fast if you've ever followed one. They obviously can't fly around the corners with patients inside, so they go at a steady speed, 60 or so on 70. But there's also the rapid response vehicles, the paramedics who are in the kind of standard car. They also have to be located across the network too, and they typically get to an incident first because they're faster if they're available. So they can treat the patient on scene, but they can't transport the patient to one of these hospitals if required. So the orange dots represent the major hospitals across our region. And they would typically take you to the nearest hospital, or they might divert if there's capacity issues at ED. So a rapid response vehicle gets there first typically, but can't take the patient. So they have to wait anyhow for an ambulance to arrive to transport the patient to hospital. So there was also lots of issues also about, do we send automatically both type of vehicles to a 999 call category A, or do we hold back the ambulance and send a paramedic? And there was all these other kind of interesting questions that they wanted to look at. And also the fundamental question for them was, where do we locate? How do we distribute our fleet of ambulances across these ambulance stations? So currently, for example, Monmouth has one ambulance, but it's only open for 7 hours a day. So if you happen to be sick at 9 o'clock at night, it's tough, it's shut. So there's not just the allocations, but also how long they're open for and how you staff those ambulance stations. And of course, we're talking about finite resources. We've not got the luxury of saying, let's have another 10 ambulances or so. It's how do we best locate our current capacity? But also, if we did have money, how would we distribute that? How would we invest extra capacity into, and where would we place it? Would we place it in the centre of Cardiff? Would we put it on the outskirts and so forth? So this is, if you work in this area, it's a kind of traditional location and allocation type problems, but the interesting thing again here is the geography in terms of the road networks, because just like many parts of the country, well, in certain South Wales, there's the M4 here, so that's fairly fast. Well, not always, actually, because I travel down and I hit the traffic here, and I crawl into Cardiff every day. But actually, this is the valleys, so you can see it's interesting, the road networks, because of the coal mining and the former coal mining communities in the valleys. And so actually, there's lots of roads which are very slow and very difficult for ambulances to go very fast down some of these major routes. So we have to also keep in mind the travel speeds of ambulances. So it's not sufficient to talk about Euclidean distances like many papers talk about as the crow flies, because clearly going from here to, say, here is not just a direct route of 20 minutes. So obviously we use our apps, we use Google Maps and so on, but a lot of the literature still talks about distances as in assuming that it's Euclidean. So we also did a lot of work around using Google Maps. In fact, if anybody has any interest in this and wants it for their own research, there is a piece of software that we had one of our internships, intern students build over the summer called PatMap, which is on GitHub. Again, if you just email me after. What's nice about this tool, really helpful for any kind of location analysis, is that you can use Google Maps functionality, look at any map, you can locate, pinpoint on the map any kind of your points, and it will return for you the distance and time travel matrices from point to point. So it basically queries Google Maps from A to B and every other combination. Now, it saves you having to sit there for a long while and do this, but also Google Maps actually constrains how many queries you can hit off in a day. I don't know if you've realized, if you really are a heavy user of it, it controls how many times you can query Google Maps. So this even optimizes the speed at which it sends the queries. If it's a massive matrix, it will actually optimize the rate at which it does that to get the matrix back in the fastest time. So it's just a nice piece of software which is useful for these types of problems. So we use PatMap to get our distance and travel matrices back. As for the ambulances' speed, we also had to do a little bit of calibration because ambulances, as I said, don't always travel at the speed at which Google Maps would suggest they could. So one of the fundamental things for doing this as well, motivation, was actually this represents the kind of current gold standard. So the 8-minute response time, if you meet a category A call within 8 minutes, it's deemed a success. And it's counted, and Welsh Government thinks that's good. And this is also England as well, they're saying. If it's 8 minutes and 1, it's deemed a failure. So it's binary, so it's yes or no, basically. So it seems a bit of arbitrary to measure the performance of a whole ambulance system on the 8 minutes. Now, the 8 minutes apparently comes from the history books of around cardiac arrest. So 8 minutes is roughly around when you need to perhaps respond to a heart attack. Is a kind of life and death situation, but no one knows for sure actually. But many countries use 8 minutes as the kind of target time. What we wanted to move towards was actually some interesting research again. Would the distribution, the allocation of ambulances or paramedics across the network, would it change if you were, rather than time targets, looking at outcomes? So moving to survival curves. So this actually is a same survival curve but for cardiac arrest from medical literature. So this is the probability of survival given the response time. So you can see kind of survival curve. But there are several published survival curves for different types of condition like stroke and heart attacks, but not many, unfortunately. So we wanted to say, rather than kind of allocation on a hard target, what if we were to try to maximize outcome rather than minimize response time based on survival curves? And that led to a whole nicer piece of, again, nice OR in terms of Leanne's work, which was looking at optimization methods for maximize survival location type problems. But again, the interesting mass here is that you're now talking about heterogeneous patients and fleets. So by that I mean different types of patient classes, so pediatrics, strokes, heart attacks, and different type of vehicles, ambulances and paramedics. So you've got different combinations. So the model allows you to define what types of classes of patients. So if I go back very quickly to that map here, so if we assume that we know the demand, say from Cwmbran, we've got forecast of demand, but what does that demand look like? A patient is just not a patient, is a patient. So that patient might be, for example, there might be high incidence of respiratory problems. It's a former mining community. Maybe there's a lot of respiratory problems. Maybe there's a lot of children, pediatric type problems. Maybe there's more heart attacks up in the valleys than there are in other areas of South Wales. So we start to get into the detail of saying what type of demand is going to call for 999. And that might influence then what type of ambulance do you require, or the demand for ambulances based on the type of category of call and the type of class of patient, as well as the different types of vehicle. So again, not the detail here. I can share published papers on this if it's of interest. But actually, the probability of survival is made up of a whole lot of conditions, which ends up with interesting equations which you can then feed into some sort of optimizer. And Leanne also built a nice simulation model So we simulate the life of the ambulance system for a week, say, and what it allows you to do is change demand. So things we did in the simulation model. What if demand went up by 10%? What if there's a major event? How long would it take the ambulance system to settle back into some steady state? What if we change vehicle capacity and so forth? Now, the headlines from all of this piece of work really were that for the rostering, they'd really need to change their roster schedule. They need to stagger start and end times, and they need to change that. For the allocation type problems, actually, we showed them where they should optimally locate their vehicles. But actually, the headline was, if you did consider moving to outcome measures, the allocations would change. The subtleties of the different types of demand in the valleys and so forth, and the different types of need, would actually give you a different allocation of vehicles across the network. So that was interesting. And I think it's the first time that had really been looked at in the literature. There's lots of people, there's people in Canada, if you were in this field, Edmonton, for example, I don't know why Edmonton, but people in Edmonton look at, there's a lot of ambulance work going on in Canada, interesting work. New Zealand, Auckland, there's a group there do some stuff, but people haven't traditionally looked at it by outcome. Most of them have done just a time target type approach. That was some interesting research. I want to finish off on this bit about reduced turnaround time, because also another piece of work we did was map the whole ambulance journey. So from the time a 999 call is made to dispatch when a vehicle is available, the time on scene spending treating the patient, the time travel in then to the hospital if required, and the time at the hospital before the ambulance is free on it to go on its way again. Now this turnaround time is the time when an ambulance arrives at the emergency department. Sometimes you might go to hospital, you see them queued up outside the A&E department. The time that the paramedics are with the patient in the hospital, handing over the patient to the A&E staff, and then when they're free now to respond to another 999 call. Now, bizarrely, the longest part of that whole ambulance journey, roughly 2 hours in total, is the turnaround time. It was, on average, for Wales, it was 35 minutes on average. That's an average. Some people were in the ambulance for 2 hours, or handover time for 2 hours, and it was discovered that actually, if the A&E was busy, and they have their own targets, they're 4 hours, which is up for discussion at the moment, if they're busy, and the patient is in an ambulance outside but stable, then there's no incentive to take that patient because the clock starts ticking as soon as it's handed over. So they actually didn't take the patient. So the patient was spending 2 hours in an ambulance outside. There's a big queue of ambulances. There's typically 6 or 7 ambulances outside Cardiff, the University Hospital of Wales. It's an expensive trolley. And also, people like me are phoning 999 and there's no ambulance in. Well, they're queuing up outside the hospital. Great. So we looked at wanted to see what would be the benefit of reducing that turnaround time. Actually, the government target, the Welsh government target is 20 minutes, but the average was 30 minutes, and more like some people 2 hours. So this was big headline news at the time too. So there was a scandal about patients faced long queues and ambulances outside A&E, and it was not just Wales, it was also in England and so forth. But no one had really quantified the impact of trying to reduce turnaround time and what the impact would be on the front end of the service in terms of the ability to meet the 8-minute response time target. I won't go into details here, but if you just believe me that you need 15 ambulances for the Cardiff region to meet the government 65% target for 8 minutes, say, with the current capacity. That's the current turnaround time. What this graph shows is that if you actually reduce your turnaround time, then obviously your performance at the front end starts to rise. Now, if you get to the government 20-minute target, you go from 65% up to 77%. So just by doing absolutely nothing in terms of capacity, you can improve your front end of the service quite markedly, just by making sure you meet the 20-minute target timeline. If you can actually get up towards here, rapid turnaround times, then you're actually almost meeting all your Category A calls within 8 minutes. Now, this is a little bit ambitious. This is a turnaround time of 7 minutes. When we talked to the paramedics, they said it was feasible if there was the right interface with the automated handover and not having to do handwritten notes, etc., then there's no reason why a 7-minute turnaround time is not unreasonable. There was once a Top Gear special. Didn't we see that when they had ambulances and the ambulances spun around and the patient was shot out the back of the ambulance through the front door? It was Top Gear style. I'm not talking quite that kind of drastic measures when they just fly by the hospital and a patient stretchers pulled out the back, but actually it's potentially feasible. And it shows you what you can do with the capacity. Now, of course, I'm not so naive to think also that paramedics also need time out. They're working solidly, so they sometimes go a bit slow too. They need a coffee, they need a refresh. That comes back to some behavioural OR, which I'll talk about at the end, which I find fascinating too. But anyway, that graph was very influential to Welsh Government to show for the first time what the impact would be. That led to investments in the interface of care at many A&Es across South Wales, a dedicated team to dispatch, to bring in patients from ambulances, to enable ambulances to get on their way much quicker. And that has had some impact in the performance as well. And also some of the other impact here, you can see that actually there's been a big urge to scrap the 8-minute target time completely and move to outcomes. And that's easier said than done because we still need more work about actually what the outcome is. Because once they get into the hospital, they don't tie the NHS number necessarily to the ambulance number, so we don't know what happened to that patient eventually. Did they survive or die, and how long they were in hospital for? So that's further work, but some interesting work, I think. And there's a whole bunch of papers there, if you're interested in. I can send people the any link they like. But what's nice about this whole piece of work, from one personal experience, is that we had a number of publications in some good journals and some really nice types of application, from the forecasting work through to some more of the location work and time-dependent research. So that was just one case study I wanted to give about some of the initial impact. What happened then was, after several years of talking to Welsh Government about what OR could offer in terms of something a bit new for healthcare services in Wales, is that I had a bit of a breakthrough eventually when the chief executive of an Iron Bevan University Health Board. Now, the way that healthcare system works in Wales is a bit different from England. We have 7 health boards, so it's geographic, but we don't have perhaps the level of complexity that people have in England, in terms of we don't have commissioning, clinical kind of commissioning groups. We just have one health board which covers one geography, and that covers primary, secondary and tertiary care all in one health board. So we're working with, in particular, the Iron Bevan University Health Board in South Wales. And the chief executive actually joined, Andrew Goodall, and he was a quantitative, it's quite refreshing, he was a quantitative chief exec. He came from a more math business background, and he really got the idea about how modelling could help. Until then, it was quite frustrating. Many of the chief execs I spoke to when I first joined Cardiff were more qualitative, and people were very busy. They went back to their busy day lives and nothing, and they said, it was very exciting, Paul, thank you, and then you never hear anything else. But Andrew Goodall really got this, and he bought into this and said, we need a team of operational researchers in the Iron Bevan Health Board. So that led to 5 years so far of an excellent relationship with NHS Wales, where we have now embedded modelling group in the health board. By that I mean that we started off with 4 research associates, postdocs. They spend their time between half the time in university, half their time in the health board. They work between. So actually, when they go into the health board, there's a picture of the health board here. There's a nice photograph when they're just all chatting and after discussions and so forth. So this is John Bolton. He's actually the a senior guy in the ABCI, in the Iron Bevan Health Board. He's a rheumatologist, so he's a clinician, and several of these are clinicians. And they're talking modelling, they're talking OR, they're excited. So far, the team have done over 100 projects over the last 5 years. Some of them are very short pieces, some of them are more longer term, but a whole range of projects across many different services. And we also train staff, so the team are involved in training from basic modelling, basic spreadsheets, basic Excel, through to some more sophisticated OR modelling. We now have a programme whereby every year roughly 10 senior personnel in a health board, so they could be director of finance, they could be senior clinicians, they actually want to come on our silver modelling course. They spend 10 days learning some basic OR methods. They do some simulations, some basic optimisation and so on, and then they apply that into their home area. They go back to their home area of their business in the health board and actually do a project using the methods they've learned. So that's a really nice programme as well. So just briefly, some of the impact stories of this. And it's not all rosy. There's lots of things that don't work out, of course, which go nowhere. But there's lots of also stories now, thanks to the team effort, that we've made able to produce some impact. So some interesting research around pathway mining, so actually modelling the data, analysing the data, the large amounts of data now to actually work backwards to say what are the pathways through a healthcare system. So this is kind of machine learning type work, coupled with bed capacity plans and again, routing through processes in terms of flow through hospitals. And that's had a big impact, as you can see, in terms of quantified evidence of reducing stroke and trauma mortality. Just simply by, again, not investing hugely in terms of new resource. We don't have that luxury in the NHS, but doing better with what we have, making better decisions about the flow of patients. Timely access for stroke is critical. The first hour or so is critical in terms of identifying their stroke. It's a stroke and giving them the right treatment. And so actually doing lots of things around the flow of a hospital and scheduling of staff and theatres and so forth. There's been a lot of work over many years. Similar thing, building simulation models through the emergency department at Cardiff, University Health Board. Again, nothing necessarily in this case rocket science, just standard kind of modelling through, looking at how we can best schedule staff and so forth. But it had a drastic impact, saving £1.6 million per year. That's largely driven by redundancy now in having to go to agency staff, highly expensive agency staff to fill the gaps. So we're actually now making sure they've got the right shifts on, the right people at the right time to cover the demand, a bit like the ambulance work. I mean, how often do you get a chance to work on a whole new hospital? So this is a kind of once-in-a-generation idea. So this is a new 450 bedded acute hospital in the Health Board. It's a major transformation of services. They're going to reduce services in other areas. They're going to put it all into a new critical care, specialist care hospital called The Grange. £350 million of government money, opens in 2 years. And so the team are now, Daniel Gartner, who's the Nyren Bevan lecturer, so that's a nice thing. As well as the postdocs, we now have Daniel, who's actually funded half by the university, half by the Health Board. So he actually is a lecturer in OR, funded by the NHS Wales. He spends his time between the two. He's doing lots of nice stuff around theatre scheduling, how many theatres does the new hospital need, how many beds and so forth. And we've got a PhD students as well looking at the kind of transportation between the hospitals and so forth. So trying to cover all aspects of the new design. Finally, again, back to the 111. So this is the kind of, not, if you don't need 999, it's not as urgent as 999. There's a 111 service. Now England has a 111 service as well. Wales is rolling out this 111 service. It's a little bit designed differently. So the team were involved again in modelling of this new service. So how would demand come in over time? Where would it be located based on NHS direct calls and so forth, and simulation models of the whole kind of call process. That informed the staffing and the design of the whole 111 service, which is now rolled out across Wales. The impact in the first 6 months of the 111 was a reduction in unnecessary ambulance journeys of 26%. So that's quite a significant saving that can be reinvested into actually, again, the more critical cases. So these are people phoning for an ambulance basically for transportation or for unnecessary, not necessarily 999. So the 111 has diverted that demand away and has led to significant savings. What I want to finish on is just a little bit about behavioural OR and healthcare modelling. Now I've become really interested over the last few years, in particular around Borr. You might have heard about a lot of it as well, and you might have been to conferences where behavioural OR is talked about. And I think in healthcare, there are lots of examples where behaviours are very important. I've already alluded to some. So, for example, the paramedic, the interface of care, where the paramedic might be slowing down, the gaming that goes on in the A&E versus the ambulance. So what's the incentive of taking the patient when there's the time targets? So there's gaming going on. There's things. What about things like adherence to drugs? Some patients are told, take your antibiotics. How many of you here have actually failed to take the whole course and given up after 2 or 3 days? What about attending a clinic? You're given an appointment. Roughly 10% of patients don't attend their appointment in outpatients, so 1 in 10 patients don't show up. And that's wasted clinic time when the NHS is really up against it. So why do people not attend? Why do people give up on their drugs? Why do people play? Why is the gaming going on? And how do we as operational researchers try to reflect that? And does it make a difference in terms of the models that we build? So this isn't just healthcare now. I mean, this is wherever sector you're working in, I want you to hopefully think about it also in this way in terms of how important are behaviours and how do we try to reflect that in our decision making. Now, Borr, There's some papers here again, kind of milestone papers in the literature, is defined as the study of behavioral aspects related to the use of OR methods in the modelling, problem solving and decision support. So in essence, Borr is thought about in three areas. So there's the behaviour in models or methods, behaviour with models, and behaviour beyond models. So the in model basically is how do we design OR methods to actually capture the behavioural aspects inside the model. And that's what interests me primarily, I suppose from a more mathematical background. I'm more interested in the kind of, how do we define models that implicitly build that in. Behaviour with models, I think there's a lot more of that you see at conferences. I guess that's more of the kind of softer systems thinking ideas. It was how do you engage stakeholders in the modelling process? And that, of course, they're all equally vital. It's just not my personal, I don't get terribly excited by that as much, although it's important. So how do you get stakeholders together to build models and that process? Behaviour beyond models is then how do you actually get things implemented? How do decisions and the recommendations you make actually get implemented in practice? Now again, that is also equally important. And what I've learned from the Anara Bevan example is actually the way that OR gets its work actually used for real is typically not the OR person. We can provide all the best evidence and the best decisions for the health board, but there's an excellent team of people in the health board who are implementation scientists, and people are really, really good at talking and working with people in the health board. They're the catalysts to actually get our work embedded, implemented. So that's also important, how you work with people, behaviour beyond models. There's this concept of bounded rationality. So in decision making, rationality of individuals is limited by the information they have, the cognitive limitations of their minds, and an infinite amount of time they have to make a decision. So you're, on the spot, you have a quick decision making, or maybe you have longer time, but you still have to make a decision. Do I go for the operation or do I not? Do I take my drugs or do I not? But we know that people are partially rational. So in essence, we use heuristics to make decisions. So we try to weigh up the pros and cons of decisions, and we try to do, maybe we compute an expected utility. We can't do every single alternative action. So this is what interested me in terms of some of the decision making that goes on in the model. So again, just to finish off, some brief case studies of behaviour in model, how I got interested in this whole area. The first example actually was breast cancer screening. So I happened to be speaking to some psychologists. I was at, it must have been maybe an OR event in Canterbury, in Kent, quite a few years ago. And I was speaking to people in psychology, and they were working on a national breast cancer screening program in England at the time. And they told me this statistic, and I was like, wow, really? They said that 30% of women do not attend their mammogram when they're invited to have a breast cancer screen. So when you get to the age of 50 or 45 now, women are invited for a mammogram, a routine mammogram, and every 3 years thereafter. And for some reason, 30% or nearly 1 in 3 women do not attend. You think it's in the woman's interest to have a screen, yes? So some decision making is going on there. And this is also pertinent at the moment in terms of things like outbreaks of disease. Yes, you might have heard in things about MMR and all this kind of thing, but in terms of the herd immunity. Now this is obviously a slightly different case, but for some reason there's this issue about attendance. So there's been an awful lot of work in OR around screening programs. So you can imagine you take a woman through her life course. You simulate a woman through her life course, onset of cancer or not. So we did all this kind of nice, if you like, physiological type of modelling. So we know the tumour size at when it's detected. So we can do some back calculation methods to work out the approximate age of onset. So maybe, for example, the age of onset of cancer for most women are in their 40s actually, but they're not detectable until they're 60. Hence, the majority of women are detected for breast cancer at the age of 60. But actually, if you do the back calculations, and we're not terribly sure how the tumours grow, of course, it's unethical to watch a tumour grow. Once you see a tumour, you remove it. But we do know from data before routine screening, from self-detection, we have some idea about the rates at which tumours grow. And there's some research that says tumours grow very slowly, then a sudden spurt in growth, and then another slow. And as we try different tumour growth models, but what was interesting here was that we put in the kind of psychological factors too. So we overlay this process with a screening program. So you screen at the age of 50, 53, 56, and so on, and you see how many cancers you detect. But we also built in something called theory of planned behavior, which comes directly from psychologists. This is the kind of models that they use, TPB. And that talks about behavior as a series of norms or influences. And again, not to go into detail here, but there are three major constructs which control behavior. And it's things like, it's the things you might guess like ethnicity. So some women, some ethnic groups, the woman has less control over her decisions than others. But there's also perceived behaviour control. It's a bit like the Kylie Minogue effect in Australia. That had a positive impact. So when Kylie Minogue had breast cancer, there was a huge rise in the number of women in Australia who wanted to be screened for breast cancer. But there's lots of equally scarce stories in the press about missed cancers or misdiagnosed, and that has an influence as well in terms of attendance. So there's lots of different constructs. But what was nice about this work, and this published paper was work with Sally Brailsford at the time, this is where it really got my interest in terms of behaviour modelling, is that we were able to build in the theory of planned behaviour into each individual woman in a simulation model. So not only can you change the screening parameters, you can also change the behaviour parameters. And you can start to say, is it more cost effective to invest in changing behaviours somehow to try to get the uptake of screening increased, or is it just best to spend that money on more frequent screening, for example, given I've got a finite pot of money? So do I get better outcomes if I just screen more frequently for those who attend, or do I spend my money somehow at an education program to increase the attendance from the 30% who don't attend? And you can start to do that kind of experimentation. Then I started, when I was at Cardiff, we looked at social network analysis. So again, a really interesting area of modelling. And so this was with social scientists. So this is about smoking in schools. So the social scientists at Cardiff, they did a large longitudinal study over 3 years. They collected data from 30 secondary schools across South Wales and Bristol. So every year they went into the secondary schools. This is roughly years 8, 9 and 10, so 13, 14, so adolescence years. And they said they went to the school once a year. And they said to the students, anonymised data, they said, tell me if you smoke, yes or no, and if so, how many cigarettes you smoke a day, and a bit about parental influences as well, like do parents smoke. And tell me who are your top 5 friends. And they did this, and then the social scientists analysed the data, and they did what they can, and then we had a PhD student working with them, and so we were able to offer kind of more of an OR insight. So this is an example of one school. We saw this time and time again. So imagine this is like 12-year-olds. So these two people here in the network, each individual node is a pupil in the year group. These two pupils are smokers, the reds, okay? So the arrows represent friendships, and they're not necessarily bi-directional, because you might say I'm a friend, but you might not list me as a friend. It's all anonymised, it was all a survey. I always feel sorry for people out here. That might have been me at school, actually. They kind of, the Billy No mates. But what do we notice about these two smokers? They're fairly connected, yes? So if you know things about small world theory, or 6 degrees of separation, have you heard of that? So this concept that you can connect yourself to anyone else on this planet in 6 or less steps. So I'm a friend of Joe, who's a friend of Sarah, and so on. Nowadays, people talk about it as more like 3 to 4 degrees of separation, if you include social media. And small world theory is a similar kind of concept. But the thing is, these two people are fairly connected in the sense that centrality or degrees of separation you can get from anybody else into a few steps to these people. So they're quite popular. So these two smokers are popular kids in the year group. And why is that important? Well, if I fast forward 1 year, the same year group, you see, first of all, the bad news, assuming smoking is bad for you, there's more red dots. So that's not good. So this is now 14-year-olds. So there's more smokers. I can't remember, people always ask me why this one's covered. I forget exactly why. But you see that there are more smokers. What do we also see? We see that the friendships form around smoking. It's not perhaps unsurprising, because think back to your school time. Maybe you hung out with kids with a similar taste in music, or maybe you were good at sport, or or whatever it was. It's the same with smoking. People seem to form friendships around smoking, which is not good news really, because that's a catalyst again for that propagation through that network. And it wasn't just this school, it's time and time again you saw the same type of patterns. So from a Public Health Wales perspective, what they want to do is how do we actually intervene to try to reduce the prevalence of smoking? So what they did, they had snipers on the roof. No, they didn't. They intervened by targeted interventions, identifying from our work the connected individuals, just from simple kind of graphs like this. Working with individuals now to persuade them it's not good to smoke. And that had an effect. So in the intervention schools, the prevalence stabilized or decreased sometimes. In the other schools, it just went in this kind of pattern. So the message there from a public health perspective is behaviors, i.e. friendships, are vital in terms of propagation of information, in this case smoking, and forming friendships around that. So actually, it's not just sufficient to say to any population, eat healthy or do this or nanny state kind of thing. Actually, the message is targeted interventions using friendships, possibly as networks, as a way to get that message across is important. And I'll come back to that very briefly at the end because I've got another couple of students now, PhDs, working on something similar with obesity and with mental health and the same kind of ideas around social networks and to help with that. And there's again, the nice mathematics, not to go into detail, was that the student, Angelico, the PhD student, actually used a PageRank, a modified PageRank method. So Google uses PageRank. When you search something in Google, it basically uses a network like this. These are all now websites. So you query something like obesity, and it would look at all the interesting pages which are mostly used and cited in terms of the network to give you the top list very quickly. So PageRank does a similar thing. Now, Angelica used a modified method to actually forecast how this network would evolve over time. That was the interesting research, and that was published in the European Journal of OR a couple of years ago. Just watch this for a second. I've got time for this, I think, just a couple. That's quite fun. I find that funny still. I show. I mean that little kind of animation just show. I mean that sums up, doesn't it? Like kind of life sometimes in terms of queuing systems. And I'm going to find that fascinating because you could talk about that for a long while in terms of all the behaviours there. But why is that important, and why does it have a healthcare context? Now, again, we've done some work around patient choice and routing games. Now, I think this is really interesting, and again, I can't go into great detail in the time I have. But in Wales, we have in effect, we have a central controller system. The NHS is very different. It's almost like the roots of an Iron Bevan. It's gone back to the founder, Iron Bevan, who was born just outside Cardiff. In the sense that it's more of a kind of controlled, where you join a waiting list is almost kind of centrally controlled. Think about it crudely as that. Whereas in England, it's very much a kind of a choice agenda in theory, maybe not informed choice, but in choice of what you choose where you want to go to, have the operation, you choose a waiting list and so on in some ways. So you've got this concept of like selfish users because, if you've done anything in game theory or price of anarchy, type models, you've got the concept of selfish users make for busier systems. It's a bit like British Airways. If you want to ensure everyone gets their choice of whether they have vegetarian or fish or chicken or whatever, you'd have to have pretty much everything on offer, yes? You'd have to have twice or three times as much, whatever number of items, to ensure everyone got what they wanted, which is inefficient in some way, but then it's not upsetting other people, you see. But the concept of a selfish user, if you want to minimize which queue you join, do you want to minimize your waiting time? You want to join the shortest queue. Overall, game theory shows us generally that selfish users make overall for worse performing systems than, for example, a central controller who puts you in the waiting position based on the information that they see. It's a really interesting kind of game theory kind of concepts, and we've done some things around routing games. The same idea, decisions about which queue to join, and even more interesting stuff, and I haven't got time to go into, is whether you can see the queue or not. Observable versus unobservable queuing system. So observable queue is where you physically in the supermarket, you're making a decision. You're you're quickly analysing which queue do I join in the supermarket based on that person's got a trolley, or that person looks slightly older, so they might be slower, or that cashier looks quite young and they're trainee. So you're making these kind of decisions. Maybe you don't know what the queue looks like at all. Maybe your waiting list isn't actually advertised in terms you've got no information at all about what waiting list it is you're joining. That also changes perhaps the decision. But what we showed for Wales versus England, some work with Vince Knight's in game theory, using some examples from the actual waiting list data, was actually when you've got low demand, it makes no difference really, whether you choose or whether you have a central controller or you choose. But as you start to get to near capacity, as occupancy is higher and higher, actually, generally, the free choice actually leads to inefficiencies in terms of people overall lose out. Of course, if you've got and there will be winners and losers, of course, like that example, the animation I showed you. But generally, the average person loses out. Now, England would argue that by having more choice drives up standards of performance because the hospitals are competing. So that's another. That's another argument, another discussion for another day. That's more perhaps business school. I don't know, more economics and other things. But also, then, if you go over the demand, as in it's a saturated system with long waiting times, again, it makes no difference really in practice. So if you're in that kind of area here, then it does actually. The Welsh government might argue they're doing the right thing by having more of a central system of control. And some interesting game theory, and also some work with Honour Smith at Southampton about trust, how you grow demand, particularly in developing countries, about how people access service based on word of mouth and trust and service is also important. And finally, some very recent work. Again, if you look at the literature, there's stacks and stacks of A&E models. I mean, it must be the most over-modelled part of a whole hospital in the literature. So if you search ED or A&E models, everyone seems to have modelled an A&E service at some point using simulation typically. But what people don't tend to do is that they tend to look at the data, they've got demand, they look at how long a patient spends in the A&E department, so yes, the service time. And they typically fit a distribution to the data, so you've got like maybe 2 hours of service time, whatever, some distribution. But what people haven't tended to do is actually look at, is the service time a function of how busy the system is? Because anecdotally, when I was watching A&E, you see when the waiting room's fairly quiet, and you're called in, it's not often it's very quiet, but when you go in to see the doctor, maybe the doctor spends some time with you, they're not stressed, it's not too busy, you might spend like some time with them. As the system gets busier, as in more and more people coming into the waiting room, like if I was looking at this waiting room now, you start to feel very stressed, and so people are going through, maybe they get productivity increases. But does that sustain? Is it sustainable? And what I showed with some data, took a while to get to the data because it had to strip back for like. But this is one hospital. It's not so clear here. Maybe it's the magic of statistics, isn't it? You can actually zoom in and make it look much more dramatic. But this actually shows you this, that the waiting time, this is a service time rather, how long you spend with the doctor when there are how many people in the waiting room. It's a function of waiting room, of the number of people in front of you in the queue. So when it's empty, you spend that time. You see, as it gets busier, the service time goes down, and then actually it's not conclusive, but it seems to suggest it might be increasing after a certain point in time. So there's only one other published study I've seen about this in America, and it had it's interesting, it has similar distribution, and they actually showed, it was a different setting, it was in actually a critical care unit, but they showed that service time started to increase again. Now my hypothesis at this stage is that it's basically work fatigue. Doctors can only go at a certain speed, and actually it becomes a bit depressing if you're just working constantly and the waiting room is always filling up. So maybe they're slowing down, they just can't keep the pace. Maybe here adrenaline kicks in and they're just, productivity is increasing. Maybe here they're just taking the time they need. Maybe someone suggested to me, maybe over here, actually it's becoming so congested, actually physically you can't move around the A&E department, trolleys are in the way, and that's taking time too, it's slowing you down. But whatever way you look at it, and whatever reason, it would suggest that service time is a function of how busy the system is. So it's not necessarily satisfactory just to fit one service time distribution. Surely your model should reflect how busy the system is at that point in time. Now, this is fairly new in healthcare, but it's not perhaps, it's been looked at in other service sectors, like in restaurants and fast food chains, and you see the similar thing. People speed up if they need to get through the backlog. And so some really interesting queuing theory here. with switching thresholds. So as the service time gets busier, you can change, as the service number gets busy, you can change the service time, and you can switch between different service speeds to reflect different thresholds. And again, that's just been accepted for Journal of the OR Society. And just very quickly, as I said, we're doing something similar now with 2 PhD students, Mark and Sari. Mark's looking at the spread of obesity through social networks and the influencing factor. And Sari's doing some really nice work around an agent-based simulation model interface with a system dynamics model, looking at mental health and depression in particular. So how people progress from mild to moderate to severely depressed, but how they interact with the system. So there's a whole bunch of people out there we know in the community who actually are clinically depressed, but for whatever reason are not accessing services. They don't see their GP. And so what we're trying to show in terms of a population model is that the problem about these individuals is that if they don't get treated or counselling or see a GP or antidepressants, then of course they'll start to progress to moderate to severe depressed. And then when they present to the system, they'll be much more complex, they'll be much more expensive for the NHS. So actually, isn't it better to invest money at the front end of the service to try to get people to see their GP, to offer the right counselling early on, to stop them progressing through this agent-based model? So that's the thing that Sari's doing with the behavioural aspects built in the agent-based model. And if you're interested in this, we've also just had with Martin, Kunch and Konstantinos a paper just going to appear in JAWS, I think it's online now, which is a review of the literature around Borr and healthcare. And there's about 130 articles we found, which we could say are truly Borr articles in healthcare. And you see the distribution within, with and beyond. The majority, as I said, is mostly with models, the kind of soft system stakeholder. But there was actually quite a few in models, people trying to build a behaviour into their models. But you can access that online on JAWS. It's online at the moment. So I want, basically, my message to you, I'm just going to wrap up now, is where you can, consider behaviours and their potential impact. So challenge any assumptions on rationality, productivity, compliance. Is there gaming going on, people choice? Is it informed choice? I mean, perceptions about services, trust, reaction to change. As I haven't even got into the thing about how you get consultants, for example, to implement change, because they have, people react to change, they're resistant to change sometimes. Peer pressure, nudging, how you nudge theory, how you nudge people along that pathway to change behaviours. I think it'd be nice to see more research in this area, and certainly more applications are required to see whether it is important or perhaps not to include Borr. I would certainly advocate, from what I've done so far, behaviours are important to embed into models to get true insights. I'm going to finish off there. There are a few videos and things on my website if people are interested about some of the impact, but thank you for listening. Thanks.